Assalamu alaikum. Good evening, everyone. First of all, I would like to thank the organizers of this unique webinar focusing on endoscopic advances in our field, especially Professor Sami Alwani and Professor Osama Abdel Nasir for their invitation. Today, I would be talking about Sialendoscopy that, as you probably know, was introduced in Egypt and has been regularly practiced in Alexandria for almost 10 years now. Sialendoscopy is a relatively new procedure aiming to visualize the lumen of salivary ducts and their pathologies. It is one of the most fascinating innovations introduced in the last 2 decades in our field. It uses minimally invasive surgical techniques that allow for optical exploration of the salivary ductal system, and its beauty is that it incorporates diagnostic with interventional therapeutic procedures as the clinical scenario dictates. This relatively new endoscopic technique allows almost complete exploration of the ductal system of both the submandibular and parotid glands. The main duct, as well as the secondary and tertiary branches, can be explored in the vast majority of cases. You can see here, this is the image after the papilla. This is the main duct, secondary branches, and here is the tertiary branches. The first reported attempts to visualize ducts of the salivary glands were conducted in the early 1990s. And at first, they started using flexible scopes. The problem with that was that the scope was fragile and it was easily broken. Then some scientists started to use rigid scopes, and this was actually almost not very good because even the scope was not broken. The amount of tissue damage was too much, and there were a lot of perforations. Actually, the breakthrough started in 1998, where Marshall introduced the semi-rigid, semi-flexible scope concept paired with Storrs. This was followed by Mihalili of Israel and the Eero group in Germany. And then in 2001, 2002, Marshall introduced the full range of scopes that are available now and that we use until now commonly in Sialendoscopy. The nice thing about the semi-rigid, semi-flexible scopes is that it takes the best out of both. So the image quality and the fiber damage is good, like the rigid, and the flexible is the amount of tissue damage is more like the flexible scope. So the semi-rigid, semi-flexible scopes are better than both the flexible or the rigid, and even the maneuverability inside the ducts is much better. These are the scopes that we use now, the semi-rigid Sialendoscopes. Actually, there are 2 types of scopes available. There is the scope called the modular scope, which you have the telescope separate from the sheath, and we have the more famous all-in-one scope that has everything inside. So you have an interventional channel here in the middle. It's about 0.65 millimeter in diameter, and you have an irrigating channel here, and you have the optical channel attached to this optical lens that is away from the scope itself. This is actually the finest endoscope developed by the human so far. Imagine that everything in these 3 channels are available in this very small scope. A 1.3 or 1.6 millimeter scope has everything inside. The irrigation channel, you can see here, and the working channel, and here is the optical channel. So it's a very, very, very fine scope. For comparison with the nasal endoscope, you can see here, this is the 4 millimeter nasal endoscope that we are all familiar of, and this is much, much more thinner, and it has a separate, as you see here, optical eyepiece that's attached to endoscopic camera. For this very fine scope, you have to have special metal trays. So if you want to start doing this, you have to invest in getting a special metal tray that actually protects the scope. And you also have to get these very, very fine brushes that you actually use to clean the scope after you finish working with. And those who work with me know that after each case, I actually spare about 5 or 10 minutes of my time actually cleaning the working and the irrigation channels by myself by these very fine brushes before sending to sterilization. There are actually two types of scopes, the all-in-one scopes, developed both from Stolz. One of them is developed by Francis Marshall, the one I prefer to use, and this is the scope that I actually have been using for the last 10 years. It's a semi-rigid telescope, a 0-degree telescope, with a working length of about 12 centimeter, and has a distal angle of 5 degrees. There are 4 diameters available of this scope. You can have a diagnostic only scope, which is 0.9 millimeter, and 3 interventional scope, 1.1, 1.3, and 1.6. And you can see this is the bend at the scope that's available, the 5-degree bend. And this 5-degree bend helps you when you're doing any maneuverability inside the salivary gland or salivary ducts. The other model is called the Erlangen model. It's developed by the Eero group in Germany. And it's a little bit similar, has also the 3 channels as you can see here, but it's a little bit shorter. This has a working length of about 10 centimeter, and it is more flexible. So you can bend this scope much more easier, and it's a straight scope, and it doesn't have the 5-degree bend. The problem is that I find the maneuverability of this scope inside the ducts itself less favorable than the Marshall scope. Here you only have 3 different diameters. You have a 0.8 millimeter, which is diagnostic, and you have a 1.1 and 1.6 millimeter interventional scopes. Okay, who can benefit from sialendoscopy? The patients that can benefit from sialendoscopy are those who have recurrent parotid or submandibular gland infections of unknown etiology, chronic sialadenitis patients. Obviously, the most commonly tackled cases are the salivary duct stones or the sialolithiasis group, and the patients who have salivary duct stenosis or strictures. Recently, we've been using sialendoscopy in some other indications like juvenile recurrent parotitis, Sjögren's syndrome, radioactive iodine treatment, and we've been having some very good results in these difficult to treat cases by actually clearing the ducts by irrigation and installation of corticosteroids, and this got marvelous results in these difficult to treat patients. What do we find when we're doing sialendoscopy? What are the pathological findings we have? You can have mucus plugs, you can have ductal stenosis, or you can see salivary stones. This is how the picture of a mucus plug appears. You see this haziness in the picture. See this haziness? This is a mucus plug, and this is a stone underneath. And these are usually found in cases of juvenile recurrent parotitis, Sjögren's syndrome, or sometimes accompanied with sialolithiasis. This video shows you actually how a mucus plug looks like. See here, this haziness. This is a mucus plug inside a duct. Ductal stenosis appears like a concentric thickening or ring around a duct, as you can see here, or one of the secondary branches or tertiary branches even. And sometimes these ductal stenosis cases can be managed using either a balloon from a working channel or a side channel, a very fine balloon, 0.6 millimeter in diameter. And you can sometimes, if the stenosis is distal, you can use what we call rigid hollow bougies. These are the hollow bougies that you put inside a guide wire, and you can dilate if you have a distal stenosis. So these are examples. This is before and after dilatation, before and after dilatation. Obviously, the most important use of sialendoscopy is in the area of salivary stones. Well, salivary stones can be either solitary or multiple, and multiplicity is usually more common in the parotid than the submandibular. You can have distal, proximal, and intraglandular. And by the word distal, I mean closer to the papilla. So a proximal stone is closer to the gland itself. A distal stone is closer to the papilla. They can vary in shape, being round, elongated, or irregular. This is an example of a stone we can see inside the lumen of the main duct, and you can see here, this is what we call a floating stone. And this is actually the easiest stone to get out because the stone is not attached to the duct wall. So you can get it easily out by a wire basket. This is an example of what we call a fixed salivary duct stone. See here, while we're irrigating, this stone is fixed, it doesn't move. So this stone cannot be removed except if it is first fragmented. What are the clinical consequences of salilithiasis? It results in mechanical obstruction of the salivary duct, causing recurrent glandular swelling during meals. And we are all familiar of this. This is a submandibular chronic sialendonitis from a stone, and this is another case. And the parotid, obviously, we all see these cases, and these are increasing more with meals. This can remain transitory or be complicated by bacterial infections accompanied by fever, purulent discharge of the papilla, and painful glandular swelling. If this is neglected, it can lead to abscess formation, and even it can lead to fistula, salivary fistula drainage externally. As you can see here, this is a submandibular case with fistulas and chronic inflammation for a neglected case for several years. And this is another case here in the parotid. You can see even the skin here is necrotic with pus coming out. So this is what you get if the stone makes a total obstruction of the lumen of the salivary duct and it is neglected. What were the management strategies for salilithiasis before? We were all taught in our undergraduate teaching, the classical teaching, that if you have a distal stone close to the papilla, you can do easily an intraoral extraction. And you have a deeply located or proximal stone, you have to do a glandular resection as that gland has been destroyed by fibrosis. Well, this is what happens if you have a distal stone. You can just easily do a cut down and remove this stone. And this is actually practiced even in the era of Sialendoscopy. These are very easy stones you can get out just by doing a simple cut down under local anesthesia, even in the clinic. But what happens if you have a deeply impacted stone? The only solution, if you don't have Sialendoscopy, was to remove the entire gland along with the duct and the stone inside. And let me tell you that in my early practices, before the era of Sialendoscopy, I've done a lot of submandibular gland resections for removing these kinds of stones. And our justification for that was that the gland is fibrotic and it is a stone former and it has to be removed all in entirety. Well, that actually has been challenged by a study done, a clinical histopathological study done by Marshall. Are these glands not functioning? Are they fibrotic? Are they stone forming? Well, he got about 48 patients with submandibular gland resections and saw the histopathological patterns inside. So he found that only about 50% had subnormal histopathological patterns, and all of them were functioning actually glands. So from that, he concluded in a very beautifully demonstrated article in the very famous New England Journal of Medicine in 1999 that a conservative attitude towards salilithiasis is justified because these glands are actually functioning. Well, you think about, when you're thinking about this problem, you have to think with solving the problem actually. So think about it as a clogged plumbing situation. If you have a clogged plumbing in your drainage system, you don't remove the entire drainage system. You actually get your plumber and you remove the clog in the plumbing system, and thereby get your drainage again and solve the problem. So you have to think it this way. Well, by having Sialendoscopy, a new algorithm for salivary duct stones has arisen. This algorithm is based on the size of the stone. If it's less than 4 millimeter, this is an easy case, and you can do it Sialendoscopy using a wire basket. If it's a 4 to 8 millimeter case, you have to do some sort of fragmentation of these stones, either using laser or micro drill, and this is a little bit more difficult. If you have a very large mega stone, more than 8 millimeter, you can use what we call the combined or hybrid techniques, combined sialendoscopic and open approaches for the submandibular intraoral or for the parotid external, as I'll show you later on in the lecture. And again, this is an easy case. Before starting sialendoscopy, you have to think how to access the salivary ducts. The first thing is identifying and dilating the papilla. So we all know that the parotid duct actually drains at the Stensen's duct papilla, which is located in the inner side of the cheek, opposite the second molar tooth. And you have to remember that when the parotid duct is actually traveling, it makes this sharp bend at the mesenteric angle. So we call that the mesenteric angle bend. So the parotid duct is not a straight duct, it's actually a bent duct. As we see here in this MRI, this is the parotid gland. You can see here, this is the parotid duct, and you can see it makes this sharp turn around the mesenteric angle in order to penetrate the vaccinator and to drain intraorally. Whereas the submandibular or Walton's duct papilla is in the floor of the mouth, just on both sides of the frenulum of the tongue. And the submandibular duct is more a straight duct. It goes from the submandibular gland and straightly to the floor of the mouth on both sides of the frenulum. And always remember that the lingual nerve has this triple relation with the duct. It's actually located lateral and then underneath and then medial to the duct. If you have that in mind, you will realize that parotid and submandibular sialendoscopy are a little bit different. So in parotid sialendoscopy, finding the papilla is easier, while navigation in the duct is more difficult due to this mesenteric angle. While in the submandibular or Wharton duct, finding the papilla is more difficult because it is in looser tissue in the floor of the mouth, more delicate tissue, while navigation in the duct is a little bit easier due to a more straight duct. For actually cannulating these ducts, we have special instruments done. We have the Marshall salivary duct probes, which come in different sizes, starting from the smaller of 40 up till the size 6, which is the biggest salivary duct probe. And these are blunt-ended probes, which are very delicate. You have another dilating system, which is called the shaken salivary duct dilator, developed by Barry Shaken of the USA. And in the shaken dilator system, you have only 5 sizes of dilators labeled from 1 to 5, with also a very blunt, delicate tip in order to avoid trauma. Another useful instrument is the conical dilator, used in between dilatation of the ducts. And you have these rigid hollow bougies, which are hollow inside to allow the introduction of a guide wire inside, which has several diameters also. And this is the guide wire we use during the dilatation. This is a short video that shows you actually the procedure of dilating parotid duct. You can see here we're using the Marshall dilators. You start by the smallest size dilator inserted. Here you can notice that I'm working under the operating microscope in order to get a good view for both me and my assistant. And you can see that we introduce these very fine dilators that are blunt tipped again. We introduce it only for about 0.5 or 1 centimeter inside the opening of the Sensen's duct. You can see that we go from the smallest size up to the larger size. Very gently, very finely, because this is actually the key point, the first key point to actually allow you to get inside the duct. So you have to do it perfectly, and you have to do it atraumatically as possible. This is the conical dilator I was talking about. In between dilatations, you can use this to actually open the papilla a little bit more and to widen it, so that you can introduce your scope thereafter easier. You can see here, this is the papilla after partial dilatation. Now we can use another method, which is called the Sialendoscopy technique, introducing the guide wire inside, and these are the rigid hollow bougies I've talked to you about. We're actually putting in different sizes of bougies from smaller to bigger in order to get the dilatation you want. This is about 2.5 millimeter in diameter. So if you get that inside, you'll be easily be able to get your scope inside. So this is the picture before dilatation of the papilla, and this is the picture after dilatation of the papilla. Here you can see the papilla is wide enough to get your scope inside. This is the other technique that we use, which is using the shaken dilator. I'll be introducing or showing this in the Wharton's duct papilla or the submandibular duct papilla. Notice that the tissues here are much more delicate, so you have to be very delicate. And notice that these dilators are a little bit different. They have like a black mark on the end of the shaft that tells you where to stop when you're doing your dilatation. And notice that I'm using the non-touch technique of the papilla. I'm not holding this papilla with any forceps or anything that can do injury of the papilla. Just holding the other papilla with a cottonoid to get it out of the way. And you can see we're doing it dilatation here only in 5 steps, introducing from 1 to 5 until you get your full dilatation. Well, once you're inside, you explore your ducts, and then if you want to extract a stone, you have to use a wire basket. So the wire baskets, there are different types of wire baskets with different sizes. Usually they are 0.65 millimeter in diameter, the shaft of it, and these wire baskets are either 3, 4, or 5 wires each. And the idea is that you visualize your stone with the endoscope and then introduce your wire basket and hold the scope and extract the stone. So this is again the idea. This is the stone, wire basket inserted closed, and then you open your wire basket after the stone, and then you trap your stone, and then you extract the stone. And these are can be usually achieved for stones that are less than 4 millimeter from the Wharton's or the Sensen's duct. When you're doing that, you have to have a knowledgeable assistant, because one holds the scope and the other one is actually manipulating the basket. And I'm very lucky to have, over the years, developed a very good team that here in Alexandria that is actually very interested in the technique, and without them, I can't work in this very delicate kind of surgery. So here is an example of removal of a stone by a wire basket. You can see here the basket is inserted closed and then opened after the stone. This is obviously a small stone, about 2 or 3 millimeter in diameter. And then you trap your stone and then you extract your stone gently. The basket is inserted closed and then opened after the stone. This is obviously a small stone, about 2 or 3 millimeter in diameter. And then you trap your stone and then you extract your stone gently from inside. Sometimes if the stone is a little bit bigger, maybe 3 or 4 millimeter, it gets hooked up at the papilla, as you can see here. This is a stone that's actually hooked up at the oral end of the papilla. So there are several tricks you can do. You can actually do some milking or massaging to get the stone out, or you can do a small papillotomy here, and then after that introduce a stent inside to get your stone out. Same thing for the submandibular. Sometimes the stone is entrapped inside very deep, and then you hold it with your basket and you get it more anteriorly in location, and you can do a small cut down when it's actually not inside anymore. It's superficial in the floor of the mouth. You can do a small cut down behind the papilla and extract your stone easily after doing a small cut down and removing the stone, as you can see here. After that, it only takes about one suture here to close this defect, and then you can get your basket again outside. Here you can see the wires of the basket, and you can get the basket, and only one simple stitch does the trick and closes this incision. Well, now we can, if you're confronted with a 4 to 8 millimeter stone, what you can do, these are a little bit more difficult. You have to do some sort of fragmentation, and there are several types of fragmentation you can use. The extracorporeal shockwave lithotripsy, which is very well known in the urology field, or you can do an endoscopic lithotripsy with either laser, microdrill, or what we call the stone breaker system. Although the extracorporeal shockwave lithotripsy is very popular in urology, its success rate is much less in salivary stones. It's about 40% in submandibular, 75% in parotid, and the main problem is that it often requires multiple sessions. And the main problem actually is the clearance of the fragments, because after you break your stone, you have the fragments in, so you have to go with sialendoscopy to get your fragments out. Another method of intraluminal lithotripsy is using the laser, and you can use laser lithotripsy by using a holmium-YAG laser, but again, this can be sometimes a tedious process, and it has some problems of thermal damage that can lead to actually duct stenosis. The long operative time it takes to break bigger stones, and the generated heat can even damage your endoscope. So you have to be much careful in order to avoid scope damage. The second thing you can use for stone fragmentation is what we call a handheld microdrill. This is the microdrill in action. You can see here this drill can actually fragment the stone. It's a little bit, again, tedious, and you have to have a soft stone in order to break this stone down, and then you start getting the fragments one by one out after you fragment your stone. But again, this takes a little bit of time, and it has to be very delicate and very gentle in order to use this handheld microdrill in order to break the stone in pieces and get the fragments each one by one using the wire basket again. So this is not always useful, because especially in larger or spherical or hard stones. Another system that has been proposed is what we call the stone breaker system. It's a new system that provides intracorporeal lithotripsy using a pneumatic gas-driven piston, and it can break the stone. But the problem is that when you're doing that and the stone is trapped on the duct wall, it can lead to perforation. That's why it didn't gain FDA approval, and it's not very widely used. Okay, now if you're having a bigger stone, more than 8 millimeter, you can use what we call the combined or the hybrid technique. This is a bigger or larger parotid duct stone. You can see this stone is larger here, and leading to parotid duct obstruction and chronic parotitis, you can use a combined approach. By using this combined approach, you actually first localize your stone by a standard sialendoscopic technique, and then extract your stone using an external approach. For the parotid, you can use a mini periodical incision external approach with microscopic assistance. So first, you localize your stone using a sialendoscopy technique. You can see here, this is the stone, and you're localizing your stone. And then after that, you leave your scope in and you follow the light. The light guides you where the stone is and where your scope is. And then you do a mini periodical incision, as you can see here, and start dissecting underneath the skin, and then following the light using microscopic control. This is the light. You follow the light guides you where the stone is. And then when you're using the operating microscope, you actually dissect the duct. You can see that we're doing this dissection parallel to the facial nerve branches, and again remember that you'll be working under operating microscope, so you see everything very clearly. And this is the mega stone or the huge stone getting outside, and you use the light to actually localize the stone in the tissues of the parotid region. So this is a huge stone getting outside. The other option for that was to do a superficial parotidectomy, but obviously here you're preserving your gland, and then you close it using 7/0 or 8/0 Purine sutures to obtain a watertight closure. And then you close your mini parotidectomy incision, as you can see here. This is about 1.5 centimeter stone, a mega stone. And this is patient post-operatively. You can see a barely notable scar here, and the swelling has gone away, and he has a perfectly normal facial nerve function. Another case with an irregular stone, a Y-shaped stone, a deeply located stone. Here is the preoperative MRI salivary. You can see the duct is intact, and that gives you a good view of what you're going to be seeing endoscopically. The duct is well intact up till the stone here. Localizing the stone, again, see this very deeply located stone in the scope inside, and this marks the area of the stone. Periodical incision, and this is the stone after you get outside, exactly matching the stone that was seen in preoperative CT. Another stone, 5 millimeter, rounded stone. So this is a smaller kind of stone, again, preoperative MRI salivary. Localizing the stone with your scope. Sometimes I like to use these self-retaining retractors. They help when you're working under the operating microscope to stabilize the field after closure of the wound. And you can see here the 5 millimeter stone. So this is a smaller size stone, but rounded, which is more difficult to extract using sialendoscopy techniques only, or even for fragmentation. Patient post-operatively, barely noticeable scar. So by using this combined approach, actually by time, I've started to decrease the difficult cases, especially in the parotid, and either to use the combined approach for larger than 4 millimeter stones, or to use the sialendoscopy using the wide guide wire basket for less than 4 millimeter stones. So both were now easy cases. As you can see, sialendoscopy can manage almost all size and all location of stones with very few exceptions. Well, at the end, by time, I've started to decrease the difficult cases, especially in the parotid, and either to use the combined approach for larger than 4 millimeter stones, or to use the sialendoscopy using the wide guide wire basket for less than 4 millimeter stones. So both were now easy cases. As you can see, sialendoscopy can manage almost all size and all location of stones with very few exceptions. Well, at the end, I want to thank you very much, and I'm looking forward to seeing you in Alexandria soon, inshallah. Thank you.